So I want you to imagine that your body is dealing with a massive physiological crisis.
Right, like a total systemic emergency.
Exactly. You desperately need caloric and nutritional support just to maintain basic cellular repair, right?
Right.
But your stomach is completely offline.
It's just entirely out of commission.
Yeah. The primary gateway for your entire digestive system is, inaccessible, inflamed, or maybe it's just simply paralyzed.
Which creates a huge problem because the medical team has to figure out a way to bypass that hostile environment.
Right.
They have to deliver fuel deep into your gastrointestinal tract entirely without relying on the stomach's normal sorting processes.
Which honestly sounds like a nightmare.
Oh, it becomes this incredibly high-stakes problem of biological plumbing. When that upper gateway is compromised, finding a safe secondary route means manipulating specialized hardware through a very dark, very torturous anatomical maze.
And that brings us to the actual mechanics of how doctors pull this off. Today we're doing a deep dive into this highly technical instructional video from the YouTube channel Gautamukala S. Raju.
Yes, specifically the video titled HCC 1475-36NJ tubes.
Right. And this material, it's essentially a granular step-by-step masterclass on placing a nasojejunal or NJ feeding tube.
It really is.
But looking closely at the specific techniques Dr. Raju outlines, this isn't just a clinical walkthrough. It's this profound study in overcoming physical constraints, like friction, anatomical dead ends.
Fluid dynamics.
Yes. Fluid dynamics, and doing it all using practically nothing but human dexterity.
Well, the clinical scenarios that actually demand this procedure are what dictate those severe constraints. We're talking about patients dealing with acute pancreatitis or maybe a severe gastroesophageal reflux or diabetic gastroparesis.
Okay, so a lot of different potential crises.
Exactly. And in all of these states, introducing anything into the stomach invites disaster, whether that's agonizing pain or a critical risk of, pulmonary aspiration.
Which is when food goes into the lungs, right?
Right, exactly. So the clinical mandate is absolute. You have to bypass the stomach entirely and deploy the nutrition directly into the jejunum.
Well, actually, wait. I want to challenge the physiological premise there for a second.
Oh, okay, go for it.
Because if a patient is dealing with, say, diabetic gastroparesis, we're talking about a profound systemic failure of gastric motility, right?
Correct. The vagus nerve is damaged.
Right. The stomach muscles are effectively paralyzed.
Yeah.
So why do we assume that the jejunum, which is literally just downstream, is perfectly fine to receive and process continuous liquid nutrition? Like, why doesn't that paralysis just extend to the intestines?
That is a great question, and it actually gets into the fascinating division of labor in the enteric nervous system.
Okay.
So the stomach relies heavily on that extrinsic vagal nerve stimulation. It needs that to orchestrate its powerful churning contractions and to eventually empty through the pylorus.
Right. It needs the signal to do the heavy lifting.
Exactly. So when gastroparesis knocks that out, the stomach just turns into this stagnant reservoir. Nothing moves.
Wow.
However, the small intestine, which includes the jejunum, has a much more robust intrinsic pacemaker system.
Oh, really?
Yeah. Its peristaltic waves can often function completely independently of vagal input.
Huh. So it's basically on its own circuit.
Pretty much. So while the stomach is locked up, the jejunum is usually still fully capable of absorbing nutrients and moving them along. You just have to figure out how to transport the supplies across the dead zone of the stomach to get them there.
That's incredible. It's like routing emergency supply trucks directly to the factory processing plant because the initial sorting room is broken.
That's a perfect analogy, yeah.
But the timeline really dictates the hardware here. The video draws a hard line on this. Nasojejunal tubes are strictly for short-term enteral support.
Right, we're talking about bridging a gap of maybe a few weeks during an acute crisis.
Yeah, because if the patient is facing months of nutritional deficit, the geometry of the approach changes entirely. Then you're looking at a PEG tube, which goes percutaneously straight through the abdominal wall.
Exactly. But for the short-term crisis, we are going in through the nose.
And the hardware loadout for this nasal route is shockingly minimalistic. We're looking at a guide wire, some gauze, lubricant, a syringe, and the NJ tube itself, which the source specifies is typically a 12 French diameter.
Yeah, and to give you a visual, a 12 French tube is roughly 4 millimeters across.
Okay, so tiny.
Very tiny. Imagine a hollow piece of cooked spaghetti that is 4 feet long.
Oh, wow.
Now you have to push that incredibly flexible, flimsy material through the nasal cavity, down the pharynx, through the esophagus, navigate the wide, cavernous space of the stomach without it curling up on itself.
Good luck with that.
Right. Then negotiate the sharp C-loop of the duodenum, and finally anchor it in the jejunum.
That sounds impossible.
It is if you do it wrong.
Oh.
The sheer lack of rigidity in a 12 French tube makes it impossible to just push it in blindly. It would coil instantly the very moment it hit resistance.
Right, so the journey obviously requires a guide, but what I loved in the video is that the very first step in establishing that path is remarkably low-tech.
Oh, it really is.
Before any scopes or wires are prepped or anything, the physician simply asks you, the patient, which nostril you breathe better out of.
It's so basic, but so critical. Assessing the nasal valve and septum deviations based on the patient's own airflow is honestly the most reliable way to find the path of least physical resistance.
Because everyone's anatomy is a little wonky.
Exactly. And introducing a foreign object into the highly vascularized nasal conchae is inherently traumatic. You want to use the widest natural aperture available.
Right. And from there, the preparation of that aperture branches into two distinct protocols, depending on, what resources you have in the room.
Yes, the luxury approach versus the standard approach.
Exactly. In an ideal environment, what the video essentially frames as a luxury, an anesthesiologist puts the patient completely under and places a wide-bore nasopharyngeal airway tube.
Right, which essentially acts as a protective plastic sleeve. It isolates the delicate nasal mucosa from the friction of the endoscope that's about to pass through.
But of course, general anesthesia isn't always viable or even available.
No, it's not. And when the physician has to proceed with an awake patient, the protocol shifts. They use local anesthetics combined with a topical vasospastic agent applied deep within the chosen nostril.
Okay, and I have to stop here because the pharmacology of that vasospastic agent is doing a lot of heavy lifting.
Oh, absolutely.
Because initially, if you tell me you're applying something that aggressively constricts blood vessels, I'd assume it's purely a strategy to prevent an active nosebleed while you're maneuvering the scope.
Which makes sense, logically.
Right. But the video notes this is primarily about preventing delayed patient discomfort long after the procedure is totally over.
Yeah, you have to consider the physical trauma occurring at a microscopic level here. The nasal turbinates are essentially erectile tissue, right? They're engorged with blood to warm and humidify the air you breathe.
Right, they act like little radiators.
Exactly. So if you drag an endoscope against that engorged tissue, the shearing forces cause microabrasions. And the immediate physiological response to that trauma is massive inflammation. The tissue swells drastically.
Which means an hour after the patient wakes up, that floppy 12 French tube is suddenly being crushed by inflamed nasal tissue.
Yes.
Causing just constant agonizing pressure in their nose.
Precisely. It's miserable. So, by applying a vasospastic agent beforehand, you chemically shrink those turbinates. You maximize the cross-sectional area of the nasal lumen.
Ah, so you're physically pulling the delicate tissues away from the friction zone of the scope.
Exactly. It's preemptive pain management through anatomical manipulation.
I love that. Preemptive pain management. So, with the pathway chemically widened and numbed, the actual navigation begins.
Here we go.
The physician introduces a slim endoscope, which is basically a highly flexible camera through the nose, down the esophagus, and into the stomach. But because the stomach is the compromised dead zone, they can't stop there.
No, they have to keep driving. They have to steer this camera through the pyloric sphincter, navigate those sharp anatomical turns of the duodenum, and push deep into the jejunum.
But reaching the jejunum is only the first half of the mechanical puzzle, right? Because now you have a camera in the exact correct position.
Right.
But a camera can't deliver liquid nutrition.
Yeah.
You need the actual 12 French feeding tube in that exact spot.
And you can't just tape the two tubes together and push them down at the same time?
No, the nasal cavity and the pylorus are way too narrow to accommodate both simultaneously. You'd never get them through.
Exactly. So you have to remove the endoscope and insert the feeding tube, all without losing your exact coordinates in the dark.
Which initiates the Seldinger technique. And this relies on a guide wire to maintain the pathway. So the physician feeds a long metallic guide wire down through the working channel of the endoscope right until the tip of the wire rests securely in the jejunum.
Right. And then the endoscope has to be slowly withdrawn over the wire, leaving only this thin metallic breadcrumb trail behind.
And the video really treats this withdrawal phase as the most precarious moment of the entire operation. The overwhelming danger here is slippage.
Oh, the physics of withdrawing that scope are working entirely against the physician.
Because it's a tight squeeze.
Well, the endoscope is woven through the curves of the patient's anatomy. So as the doctor pulls the scope backward, the friction of the scope's internal channel grips the guide wire.
Ah, I see.
Furthermore, the tortuosity of the stomach's greater curvature creates mechanical drag. If the physician simply pulls the scope out, the friction will drag the guide wire right back out of the jejunum along with it.
The guide wire falls back into the stomach, the pathway is lost, and boom, the entire procedure resets.
You're back to square one.
So to prevent this, the physician has to physically grip the wire at the nose, applying exact counterpressure to overcome that internal friction as the scope slides out.
Which takes a lot of feel.
Right. And assuming they maintain that tension and successfully isolate the wire, we reach the critical junction of getting that floppy 12 French tube over the metal track.
Now, the clinical environment dictates the risk profile of this next step. Because if the facility has live fluoroscopy, continuous X-ray imaging, the physician can visually track the radiopaque guide wire inside the body.
Oh, so they can actually see what they're doing.
Exact. They can physically see if the wire begins to bow or slip as they advance the feeding tube.
But fluoroscopy requires specialized suites and technicians. It's another luxury.
Yeah, it's not always there.
So the video details a highly specific tactile protocol for when physicians have to execute this exchange essentially blind, relying entirely on what they call a one-to-one exchange between the doctor and their assistant.
Without visual confirmation, vectors of force and tension are literally the only metrics you have. The guide wire essentially functions as a tightrope.
Okay.
The assistant stands at the head of the bed, holding the proximal end of the wire, and their sole responsibility is to maintain absolute, unyielding tension, making sure the wire remains taut without a single kink.
Because if the assistant allows even an inch of slack, advancing the feeding tube over the wire will cause the wire to bow outward inside that cavernous space of the stomach.
Right. And pushing a plastic tube over a bowed metal wire creates a sharp loop.
Which sounds dangerous.
Very. It can easily perforate the gastric wall or the delicate lining of the duodenum.
Yikes. So the synchronization has to be flawless. The doctor advances the feeding tube forward exactly 1 inch, and the assistant must simultaneously yield exactly 1 inch of the wire.
Yeah, they are feeding the train down the track by feel alone.
But there is a vital hydraulic component to this physical exchange that the video highlights, and I think this is brilliant. Before the doctor even attempts to thread the NJ tube over the wire, they take a syringe and flush the internal channel of the feeding tube with water. They thoroughly lubricate it.
Well, you have to. We are dealing with massive surface area friction here. You have 4 feet of dry plastic tubing sliding over 4 feet of dry metal wire. The coefficient of friction there is staggering. Attempting to force that connection dry would require so much forward pressure that the guide wire would inevitably kink inside the patient.
I think of it as the mechanical equivalent of trying to thread a wet noodle over a jagged wire in the dark,
right,
without accidentally pulling the wire out of a maze.
Well, that's exactly what it's like.
Yeah.
But injecting the water changes the physical dynamics entirely. It creates a microscopic hydrodynamic boundary layer inside the lumen of the feeding tube.
So the plastic is no longer scraping against the metal.
Right. It's hydroplaning over a thin column of water. That fluid dynamics trick is honestly the only reason the sheer physical dexterity of the one-to-one exchange is even possible.
Wow. Okay, but all of this, the one-to-one exchange, the hydroplaning, it all assumes you successfully navigated the slim endoscope through the nose in the first place.
Right.
But the video throws a massive logistical curveball here. What if the patient's nasal anatomy is just too restricted? Or, what if the hospital simply doesn't have an ultra-thin nasal scope in their inventory that day?
Then the medical team is forced to use a standard, thicker endoscope, which physically cannot pass through the nasal cavity.
So what do?
They have to route the standard scope through the mouth.
Okay.
Anatomically, the pathway to the jejunum is identical once you pass the oropharynx. So placing the guide wire via the mouth is pretty straightforward. The endoscope goes in, the guide wire goes down to the jejunum, and the endoscope is withdrawn.
But, okay, wait, now you have a massive geometric routing problem?
Yes, you do.
The guide wire is hanging out of the patient's mouth.
Mm-hmm.
But a nasogenal tube, by definition, must be secured to the nose.
Right.
You can't just leave a feeding tube taped to a patient's lip for 3 weeks. They wouldn't be able to speak or swallow saliva or even close their jaw without biting the tube and cutting off their own nutrition.
No, the wire absolutely has to emerge from the nostril.
So how do they fix that?
Moving a wire that is anchored deep in the intestines from the mouth to the nose without pulling it out of the jejunum requires this brilliant improvised maneuver.
A total MacGyver move.
Exactly. The physician takes a separate, empty catheter, just a hollow plastic sheath, and inserts it into the patient's nose, driving it down the back of the throat until the distal end emerges out of the mouth.
So you essentially create a hollow plastic tunnel connecting the nostril to the oral cavity.
Exactly. Then the physician takes the proximal end of the guide wire that's hanging out of the mouth and threads it up into that hollow catheter.
Okay, following.
They then go back up to the nose, grab the top of the catheter, and pull it completely out. As the catheter retracts, it drags the guide wire retrograde up from the mouth, around the soft palate, and out through the nostril.
But wait, the mechanics of that reroute seem incredibly dangerous to the placement of the wire.
Why do you say that?
Because you're creating a severe U-turn in the back of the throat. When the doctor pulls the catheter out of the nose, the vector of force is pulling straight up. How does that upward traction not immediately yank the distal end of the wire right out of the jejunum?
That geometric vulnerability is exactly why the video details a highly specific physical anchor technique. You can't just pull from the top. You have to isolate the tension.
How?
While one hand is pulling the catheter out of the nose, the physician literally reaches their other hand deep into the patient's mouth and presses a finger firmly against the back of the throat.
Wait, really? They use a finger?
Yes, they are physically pinning the wire against the patient's internal anatomy. They press the guide wire against the posterior pharyngeal wall, essentially trapping it against the rigid structure of the cervical spine located just behind the pharynx.
Oh, wow.
By pinning the wire against that immovable anatomical landmark, the physician creates a temporary fixed origin point.
That's genius.
Yeah.
The finger X is a mechanical clamp.
Exactly.
So all the upward pulling force required to drag the wire out of the nose is isolated to just the few inches between the pharynx and the nostril. The 4 feet of wire hanging below the finger, stretching all the way down into the jejunum, experiences zero tension.
Zero tension. And once the end of the wire is successfully retrieved from the nostril, the physician removes their finger, releasing the anchor. The routing geometry is solved.
That is wild.
The wire is now emerging from the nose, safely anchored in the jejunum, and the team can proceed with the standard Seldinger technique, flushing the feeding tube with water and advancing it over the newly routed wire.
And after confirming the placement with an X-ray, the guide wire is removed, the tube is taped securely to the bridge of the nose, and the emergency supply line is officially open.
Yep.
The dead zone of the stomach is completely bypassed. The patient immediately begins receiving the caloric support they need to survive the crisis.
You know, breaking down the granular steps of this protocol reveals a really stark contrast in how we perceive modern medicine.
How so?
Well, we culturally associate advanced medical care with digital automation, robotic precision, algorithmic diagnostics, right?
For lasers and supercomputers.
Exactly. Yet, establishing this life-saving nutritional lifeline relies heavily on fundamental physical principles and raw tactile feedback.
It really does. It requires a physician to intuitively understand the coefficient of friction inside a wet plastic tube,
Wow.
to visualize the vectors of tension on a hidden wire, and to leverage the rigid anatomy of the cervical spine with a single finger just to manipulate a mechanical system.
It is a profound demonstration of anatomical engineering performed entirely by human hands. The equipment is remarkably basic: a wire, a plastic tube, and some water. But the application of those tools demands an exceptional level of spatial awareness and dynamic problem solving.
It's biological plumbing, executed under immense physiological constraints.
Exactly.
And it leaves you with a really fascinating tension to consider regarding the future of medical training, because we are rapidly moving toward an ecosystem of robotic surgeries, AI-assisted navigation, and highly automated clinical environments.
We absolutely are.
But the techniques outlined in this procedure, feeling the subtle resistance of a kinking guide wire, or knowing exactly how much pressure to apply to the posterior pharyngeal wall with your finger, they are inherently tactile.
Very much so.
So, as the medical field continues to prioritize high-tech, automated solutions, how do we ensure these deeply physical mechanical skills are preserved? You have to wonder, will the sheer artistry of a physician navigating a guide wire by feel eventually become a lost art? Or will these raw, hands-on maneuvers always remain the critical fail-safes when the digital infrastructure inevitably falls short?
It's a great question.
It really changes how you view the invisible mechanical solutions keeping patients alive every day.